I would like to thank you for being present here today. I know that you could have been anywhere and you're here, so thank you. I'll go ahead and we'll begin. Let me introduce you to Dr. Audrey Snyder. Is a passionate nurse practitioner, educator, and researcher with a PhD in nursing from the University of Virginia. She's a professor and associate dean for community engagement and academic partnerships in the School of Nursing at the University of North Carolina, Greensboro. She's a life member of the Emergency Nurses Association and a member of the American Association for the History of Nursing. She enjoys the history that nursing brings to all aspects of her work, and I say amen to that. She's been honored as a fellow in the American Academy of Nurse Practitioners, the Academy of Emergency Nurses, and the American Academy of Nursing. She's a recipient of the 2023 Lillian Walsh Humanitarian Award by the National League for Nursing. Dr. Snyder received the 2021 Karen and Terrence Holm Visiting Scholar Award. It is a pleasure to welcome her to the MNHRC Home Speaker Series on the history of nursing as she presents Let's Do It, Advances in Emergency Nursing Practice. It's all yours, Dr. Snyder.
Thank you, Dr. Flynn, for that wonderful introduction. And thanks to each of you for being present today. Before I get into my presentation, I'd like to also say thank you for the Holm Visiting Scholar Award, which I received in 2021. And this is part of the outcomes of the work from that award. I also want to say that I've been a member of the Emergency Nurses Association for the last 35 years. So there are some things in my presentation that have come from my personal collection. Otherwise, photos that you see have been from the ENA archives there at the Midwest Nursing History Research Center or from the Emergency Nurses Association headquarters. Otherwise, they're noted as being different. So the purpose of this exploratory study was to describe the advances in emergency nursing practice in the United States, its role in shaping disaster preparedness and response, and any influences that the Emergency Nurses Association had on emergency nursing internationally. Methods were traditional historical methods with a social history framework examining events in the context of time, place, and social interactions. For data collection, data immersion, and developing a chronology and themes, which I tried to incorporate into a historical narrative. Primary sources were legal documents, journals of the time period, and other manuscripts in the ENA collection at the UIC Midwest Nursing History Center, as well as the Emergency Nurses Association headquarters in Schaumburg, Illinois, along with a few news records of the time. In the early 20th century, care was provided in first aid rooms and other dispensaries across the nation. Many of these closed, and patients turned to modern hospitals for care. Despite the fact that hospitals were growing in size and complexity and becoming increasingly dependent on technology, for most of the first half of the 20th century, few hospitals had emergency rooms as they are known today. The first emergency rooms evolved for the need to provide after-hours care for accident victims. These early rooms had various names: accident room, first aid room, emergency ward, and accident unit. By the 1950s and 60s, however, there was a dramatic increase in the number and the use of hospital emergency rooms, or ERs as it was abbreviated, and the number of patients turning to them for care. According to one historian, these ERs were staffed by minimally trained physicians or unsupervised residents or just nurses backed up by doctors on call from home. Others described three types of ERs that predominated in the 1960s. The first, a 24-hour comprehensive emergency facility that was equipped to render complex and comprehensive care. The second, a limited ER with an on-call resident. And the third, a provisional ER unit, a small hospital that depended on an RN to make the initial assessment, call a physician, and give care until the physician arrived. In many cases, nurses staffed other areas of the hospital until a patient rang a doorbell and presented to the ER for care. And at that time, the nurse would run down and open the door. In the mid-20th century, nurses often provided care without the physician present. They were left to diagnose and treat patients on their own before the doctor arrived. Organizing nursing was defining the scope of practice in a way that would limit these nurses' ability to function. In fact, in 1965, the model definition of nursing by ANA, or the American Nurses Association, had serious implications for ER nurses' practice. Of particular significance was the fact that in that definition, the ANA limited nurses from acts of diagnosis and prescription. And according to their definition, quote, the practice of professional nursing means the performance for compensation of any act in the observation, care, and counsel of the ill, or in the maintenance of health or prevention of illness, or the administration of medications and treatments as prescribed by a licensed physician. The foregoing shall not be deemed to include acts of diagnosis or prescription of therapeutic or corrective measures. So for nurses caring for patients in small ERs throughout the country, that meant they were working outside of their legal scope of practice. In fact, because Nurse Practice Acts did not cover ER nurses for the de facto diagnosis and treatment, they were operating in the absence of a physician, and the legal limits were a frequent concern. A solution was on the horizon, though, because the nursing profession was increasingly focused on specialization, and the ability to specialize in emergency nursing and work in an expanded role would be an option. Federal funding actually facilitated the increased use of emergency rooms. Providing hospital beds was met by federal funding in the establishment of Blue Cross. The Hill-Burton Act that passed in 1946 matched a third of the hospital construction cost with priority given to rural areas. And from 1946 to 1975, $4 billion was provided and 425,000 new hospital beds were added to healthcare facilities between 1946 and 1968. Administrators in the hospital started to add clearly designated emergency care facilities to their plans. And an entire journal of hospitals, the Journal of the American Hospital Association in 1957, was dedicated to the planning and construction of emergency rooms. The American Hospital Association helped in the creation of Blue Cross Health Insurance in the hope of increasing business to fill these newly allocated beds. A community service and uncompensated care obligation was attached to that funding, and a significant change in access to care for the general public. Now that there was not a financial barrier, the emergency room became a source of both emergency and primary care. Another federal initiative would also affect nursing. In this case, it would affect the use for primary care. In 1965, Medicare and Medicaid legislation signed by President Lyndon B. Johnson under his Great Society program provided health services for the elderly and the poor by providing co-payments for their cares to the hospital. This resulted in more patients coming to the hospital via the route of the ER, as private physicians turned away those patients who did not have private insurance. It was in this context that the emergency nursing specialty developed. Anita Dorr, an emergency nurse in New York, and Judith Kelleher, an emergency nurse in California, each formed an Emergency Nurses Association in 1970. An RN magazine editor heard Keller speak in California and told her about Dorr's efforts in New York. When they learned of each other's work, they corresponded and agreed to combine efforts for a national organization. And Keller insisted that the name be Emergency Department Nurses Association. It was chartered December 21st, 1970 in Albany, New York, with a membership fee of $5. In these fledgling years, there were many challenges, and whenever one arose, the nursing leaders said, let's just do it. Regional directors were appointed in 1971, and they met in Buffalo to create a board of directors, bylaws, and constitution. The eDNA was created to see a unified voice, to provide education and networking opportunities, and to set standard of excellence for emergency nurses, for co-founder Judith Keller. In October of '73, she became the first titled president of the Emergency Department Nurses Association. The association grew rapidly across the nation, supporting and crafting the evolving role of the emergency nurse. The board of directors developed a plan for certification, created an annual conference, wrote a core curriculum, that included advanced nursing assessment and decision-making. This collaboration and communication was noteworthy in the day of long-distance calls and letters on electric typewriters sent by mail. This group of nurses was supported by the American Academy of Orthopedic Surgeons, the American College of Surgeons, and the American College of Emergency Physicians. Unfortunately, Anita Dorr, the first executive director, died just days before the first conference in October of 1972. At that time, the organization needed to move from Anita's basement in her home to an office, and they merged in with ASAP in East Lansing, Michigan. The first few years were very busy for these nurses. In '74, they held the first General Assembly in Washington, D.C. to develop resolutions and bylaws revisions. And in 1975, the very first issue of the Journal of Emergency Nursing, or JEN, written by and for emergency nurses, became a peer-reviewed scholarly publication and now a research journal. They published the first continuing education curriculum in 1975. And by the end of that decade, in September of '79, they hosted their first independent conference away from the American College of Emergency Physicians in Phoenix in September. The emergency nurses adopted the Roadrunner as their symbol for reasons that every emergency nurse will understand, said Anita Dorr. And because they move fast and do things, said Judith Keller. The symbol of Roadrunner became the name of the first newsletter in 1971. Performing CPR and defibrillation, reading EKGs, administering IV fluids, immobilizing fractures, performing emergency deliveries were part of a day's work for the emergency nurse. A motivation for physicians to allow nurses to perform these skills was the fact that insurance companies didn't require a physician to be present or to perform the procedure himself for the doctor to be paid. In the early years, professionalism of the organization was a major focus. Within 2 years of formation, the need for certification was highlighted and discussed at this meeting of the regional representatives of the eDNA. During these years, its aim also expanded. Keller, in her presentation to participants at the 8th International STEP Forum, spoke to this expansion, noting that the Emergency Nurses Department Association had been able to identify needs peculiar to practice, to speak on these issues intellectually, and to initiate changes in the scope of practice to achieve the status as a recognized nurse specialist. An ad hoc committee was formed in 1975 to develop a plan for certification to be endorsed by the American Nurses Association. The cost would be $500,000 to create the specialty exam. And according to the ad hoc committee, this would lead prestige to the organization. Where would the money come from? Judith had faith and she said, let's just do it. We'll figure it out. Indeed, the eDNA and its certified members would go on to be recognized and accepted as leaders. Certification would support those nurses who were working in the emergency department without a physician and would provide backup for the hospitals if there was legal action. As long as a copy of the certification was in the records and the nurses practiced to the standard of care specified, the hospital and the nurse would be legally safeguarded. This is where the "we just do it" would appear again. Judith said, "We didn't stop to worry about what was right or wrong. We did what we had to do." The emergency department serves two major healthcare needs. It's a primary healthcare facility, and in many areas, the only place non-urgent patients can be seen and treated. But also, the emergency department handles trauma victims with life-threatening injuries who needed immediate and effective treatment. And at this time, there was no national standard for how you equip an emergency department, and each emergency department varied in what they stocked. So in 1967, Anita Dorr, one of the co-founders, and her husband actually developed the crisis cart, the precursor to the modern day code cart. She felt precious time was wasted when the staff had to chase around the hospital getting all the supplies they needed for a variety of emergency cases. So she thought about the most common things and compiled a list that she thought was needed to handle any type of emergency. She measured each item and then at home worked with her husband to design and build a prototype in their garage. This was disseminated by the eDNA with a resuscitation equipment list at the Air League Conference on Emergency Medical Services that was held in 1969 in Warrenton, Virginia. The 1970s were really the formative years. Military was advancing techniques in trauma and emergency care, which emergency nurses embraced as healthcare workers returned from Vietnam. For ENA, the 70s were the days also of the formation of the organization and establishing a nurturing system that would provide for a healthy and sustainable organization. They held their first convention in 1972 to educate nurses. The same year, the skill list for emergency nursing was published and the core curriculum was completed. In less than 5 years, the structuring of the emergency nursing specialty organization, establishment of a national office, development of standards and core curriculum, and provision of educational courses, and the beginning of a certification were all accomplished by a team of energetic nurses known as Roadrunners. The focus on the creation of the specialty was emergency nursing. Now, if we look at what was happening at this time globally, on a federal front, there was an initiative to expand primary and emergency medical services. Part of this federal effort included money for EMS training and for ambulances as rescue squads. Previously, rescue squads used cars from funeral homes, and this was when funeral directors would still bring an injured person to the emergency room and ring the bell. The government was concerned about EMS and money for training, and was very concerned about the golden hour of trauma care, the time between the time when a patient is found and when they're treated at the hospital. This was the focus of the national paper, Accidental Death and Disability, the Neglected Disease of Modern Society, published in 1969 by the National Academy of Sciences. So the EMS money the government offered standardized the 911 system, developed the emergency medical technician curriculum, developed highway signs directing people to hospitals, and regionalized hospital trauma and regionalized hospitals, including trauma and community hospitals. In 73, the standards for basic life and advanced life support were created. And by 74, rescue squad personnel were required to have advanced first aid developed by the American Red Cross and to have citizen band radios to transmit messages to police officers who would then relay that information to the emergency room nurses. The 80s became a decade of independence. ENA became independent from ASAP, and when the executive director left, there was little money for operations of the eDNA. The president at the time, June Thompson, went out on a limb and asked Arthur Young and Associates to help with much boldness and determination. And in response, they believed in what the organization's mission was and provided consultative fees for free to help them get back on their feet. Vicki Patrick, who was the president the next year, said that it was this let's do it attitude of many of the nurses working in the specialty that allowed eDNA to survive these financial times. This decade was a decade of first. The first certification exam, a renaming and first issue of the newsletter to the etc., the first emergency nursing core curriculum, and the first leadership workshop for ED nurses. And in November of 1981, the very first General Assembly and Scientific Assembly was held internationally in Toronto. This was the first and last that was to be an international conference. In 1985, the name changed to the Emergency Nurses Association to reflect the many environments that emergency nurses work, not just emergency departments. The confluence of these nursing initiatives, government policies related to medical insurance, and the ANA's restrictive policy on nursing practice merged in the latter half of the 20th century to really impact emergency nursing practices, with the development of the emergency nurse practitioner role in the 70s to equip ENPs with skills to provide both primary and acute care in the surrounding rural communities. Remember, at this time, physical assessment was not even in the undergraduate curriculum, and medical management was also somewhat of a mystery, so it was very different from nursing. So these professional boundaries blurred into the ENP role. The first master's level program for emergency nursing was developed by Vicki Patrick in 1980. In 1990s, the ENP graduate programs were revived, and this led to ENA developing a first position statement on advanced practice nursing in 91 and the adoption of the scope of practice for ENPs by the Emergency Nurses Association in 99. This also led to a certification exam in 2017. The organization took on challenges in education, and in 86, they developed the trauma nursing core course and piloted it. The first code of ethics was also developed around this time, and the 80s saw a future focus on patient concerns impacting the work of nurses on a daily basis. In the 90s, there was a push from international members to be represented at the ENA General Assembly, but this would require much discussion, debate, and changes in bylaws at General Assembly meetings. Many members opposed this idea as ENA was considered an American organization, although there were international members from the beginning. Over time, this collective thought changed, and as early as 1995, the ENA Scientific Assembly brought in international speakers to address topics that affected international peers. Michael Tobin from Australia talked about venomous snakes, and John Williams of Ireland spoke on the casualties of terrorism and their care. In May of 2000, the first issue of the ENA Connection that replaced the etc. newsletter focused on, quote, "Are you prepared? Tips for counterterrorism." And this topic was timely when in 2001, the ENA conference in Orlando was canceled as terrorists struck US targets on 9/11 the day before. ENA leadership learned to respond to constant change. In this 90s this 90s decade of growth in emergency nursing, the establishment of the ENA Foundation was started to support education of emergency nurses. TNCC expanded to Australia and Canada. And ENA purchased their first building in Park Ridge, Illinois in January of 1993. The next month, they hosted the very first leadership symposium in San Diego. Pediatrics became the focus of the day, and emergency nursing pediatric course was developed, launched, and evaluated, following the format of the trauma nursing core course previously. Emergency nurses were required to think and to act quickly and to readily establish rapport with patients, to be trained in resuscitation, and based upon their experiences, they thought they needed to do something to educate the public to prevent injuries so they could decrease the number of persons coming into the emergency department. Injuries from preventable causes continued to increase, and emergency nurses cancel alcohol-related emergencies was developed in 1995 as a public education program provided by emergency department nurses, focusing on high school-age children and the prevention of alcohol-related accidents. ENA also began to train members on interrelations with government affairs and how to communicate with elected officials. They became much more politically active to focus again on laws that could help impact emergency nursing, and established the Day on the Hill in 2013 to empower nurses to have a voice with their federal lawmakers. The first emergency nursing scope and standards of practice were published in 2011. This was the same year that the American Nurses Association recognized the emergency nursing as a specialty practice and the Emergency Nurses Association as a specialty nursing association. As the Journal of Emergency Nursing became more focused on research, the Emergency Nursing newsletter, the ENA Connection, started highlighting more nursing experiences, including international. Cindy Martez shared about how she cared for patients in Haiti after the 2010 earthquake, sharing complications of respiratory illness, asthma-like symptoms. And these disasters that were shared in the emergency nursing care brought a focus on equity and disaster response. Project Helping Hands that was created by emergency nurses shared their work in Bolivia and in Kenya, serving a population of 55,000. They worked in the clinic and made house calls, screening patients and referring people for services. Education became more internationalized, as evidenced by ENA partnering with the Polish Ministry of Health to bring triage algorithms to the hospitals in Poland through virtual training and a train-the-trainer program, while considering language and cultural barriers. One of the earliest disaster reports focused on the need for preparedness for any event, not just those common to the area. Florida emergency departments were used to preparing for hurricanes, but in 1987 in Palm Bay, Florida, a man shot into a neighborhood, drove to 2 nearby shopping centers, opened fire again, and 6 persons, including 2 police officers, were dead and 14 persons injured, including a paramedic. And it took 7 hours before the gunman was apprehended. Because of the scale of this event, it was difficult to have direct communication with the hospital. Telephone gridlock occurred, and it made landline communication really impossible. One emergency department received the majority of those victims, and within 40 minutes, they had 13 patients with gunshot-related wounds. They had sent 6 to surgery, admitted others, 3 were treated and released, and 17 patients were sent to the morgue. The fact that the OR was winding down and staff physicians were closing up their nearby offices and were able to come immediately to the hospital to do vascular, thoracic, orthopedic, and neurosurgical care allowed for a rapid response, but it did not allow for disaster triage procedures. Instead, one nurse acted as the patient flow manager. These communication challenges resulted in a direct line between central dispatch and emergency departments, and separate radio frequencies for disasters through grant monies. They also learned from this event and developed an index for roles for nurses so that each could respond. With this event, there were 13 critical incident stress debriefing sessions. But from this, that they learned is that hearing the stories over and over again the actual debriefers were impacted. And there was never a debriefing for the critical incident stress debriefing teams. This changed the focus on debriefings for the future across the country. Following challenges in disaster response, as we look at what happened with Hurricanes Katrina and Rita in the Gulf Coast in 2005, there became the development of EMACs, or Emergency Medical Assistance Compacts, with federal regulations created to provide mutual assistance by professionals between states during a disaster. The Journal of Emergency Nursing became a repository of emergency nurses' experiences with this and other disasters. For example, challenges during the disaster were credentials of a person and having a means for setting up a processing center and dispensing badges to know if people were really legitimate to provide the care that was needed. Resulted in memorandums of understanding within states to help with that process. Today, we know that the Compact Nurse Registry has made this process definitely much easier. In September of 2014, the Journal of Emergency Nursing dedicated a whole journal to disaster, with a focus on emergency preparedness being more than just the drills that were being done. Following along with the federal emergency management mantra, prepare, plan, and be informed. This journal actually acknowledged the significant role the Red Cross has in leaving a legacy for disaster preparedness and response. This same year, September was designated as Emergency Preparedness Month, based upon the 9/11 terrorist attacks. This journal edition allowed nurses to share their real-life experiences in situations such as the Boston Marathon bombing and the 2013 Pediatric Mass Casualty Education Experiential Learning through university-sponsored disaster simulation. It shared the Aurora mass shooting from 2012 and a long list of disaster and emergency preparedness resources for nurses. It gave clear guidelines to emergency nurses on how to self-prepare. Another aspect of disasters are that disaster triage is very different from the 3 or 5 level triage used at that time in emergency departments. So Patty Kuntz-Hauer and Andy Foley provided an overview of disaster triage, utilizing the START simple triage and rapid treatment to help nurses prepare when mass influx of disaster victims arrived at a facility. Another challenge that was identified is that disaster guidelines focus on providing comfort on those who are expected to die, and you treat all others before you go back and re-triage those that are triaged black. And that's especially difficult when a large population may be from the older adult population. An article on ethics identified these challenges and brought to the forefront the fact that triage says green are those who can walk, when in reality, many older adults, because of their frailty or resources limitations, may not be able to. So recommendations for best practices in the management of elderly disaster victims were developed through Baylor College of Medicine for tracking systems in adult shelters that separate older adults and involve gerontologists and prepare those that can lead to better the quality of care for the older adult during a disaster. ENA continued to work globally. On an ENA trip to Seoul, South Korea for the International Council of Nurses Conference, ENA President Matt Powers, representing ENA, brought back the message: we are all ambassadors of healthcare at home and globally, especially in the control and spread of diseases like MERS and Ebola. Another key challenge highlighted was the outward migration of nurses and the need for healthcare professionals to unite and stand up and advocate for patients and nurses worldwide. Following this, global health and emerging infectious diseases began to be highlighted in the education. In 2016, Shara Lodi shared her experience working with an NGO or non-governmental organization in a war zone and displaced situation in Iraq. 3 emergency and primary health centers were established in this area. The total number of displaced persons was 28,000 persons. And she facilitated a triage model adapted to the needs of these persons and gave guidance for nurses working in this type of situation for the future. As a primary care nurse practitioner, Heidi Mulligan saw the impact of infectious diseases on the Ebola outbreak when she was there for the first 6 months, witnessing the impact of culture and belief trust in healthcare systems and communications, and how this impacted the infectious disease outbreak. As rituals for burial practices were unsafe, because continuing the practice of washing bodies exposed to people to the Ebola virus. Also, chikungunya was an issue, and she reported on this in the Latin American area and the Caribbean. This highlighted the importance of global health and the far-reaching implications that it held for emergency nursing. Understanding the culture and sharing these experiences helped other nurses as they entered this arena to provide for care. Justin Bass volunteered with Partners in Health in February of 2015 in Sierra Leone through a USAID Ebola response. Here, they decided they needed to put foreign volunteers through a week-long training program where they actually learned from survivors of Ebola. Standards were established, and the parents highlighted the fear of mistrust and social stigma and the barriers this caused for seeking care, and also for surveillance, contact tracing, and integration back into the community. As more priority was given to international work, emergencies have just done it, but they also identified pitfalls in this work. Because nurses can provide some of the best care in humanitarian response, but the potential for risk that could cause more harm than good. This was defined as a triple menace in international aid work by Tim Cunningham and Andrew Sacy. They proposed this concept as being an emergency mind trap that volunteer entitlement and leadership misinterpretation can occur in long-term settings. Thousands of aid workers have gone through these temporary shelters that are more like cities and communities, and for these people, quick fixes don't work and are difficult to implement. Volunteer entitlement can become compassion fatigue and cause breakdowns in the team. If volunteers rely on titles, they may not actually see who's leading the ground operations. So it gave an opportunity to think about how nurses step out of their comfort zones to help, but at the same time need to be aware of these challenges. Research has been more easily integrated, and assessing what stress has done on disasters has also been highlighted. Following the false ballistics alert in Hawaii in January of 2018, the question arose, did the emergency department staff respond appropriately? Could an emergency department staff respond appropriately? So emergency nurses reacted and developed a mobile education program to assess readiness for radiological and nuclear incidents. And this study found that emergency nurses favored mobile education and training to have increased knowledge just in time if something did occur. At the same time, there was a focus placed on increasing preparedness during daily shift huddles, regular emails, designated whiteboards, and staff meeting presentations to increase nurse readiness for disasters. During Russia's invasion of Ukraine, the Russian army took over a nuclear power plant, again instilling fear across the world that there may be a nuclear response. Emergency nurses stepped up to provide just-in-time education to nurses in the neighboring country of Moldova via distance technology. This was also later shared with Ukraine and Romania. Telehealth nursing was a technology that's also been implemented during disasters to help in wound care management, trauma care, and triage, to enhance surge capacity and speed the effectiveness of medical and nursing interventions. Another challenge identified by emergency nurses are nurses competent to respond to certain types of disaster situations. So in Brazil in 2020, they actually developed a self-reported instrument that could help identify educational needs for nurses for their future roles in emergency response. Reflecting on the duty of emergency nurses during the global coronavirus pandemic, which has been our most recent disaster, emergency departments have been rising to the occasion to deal with disasters both before and after. And there's been an increased focus on disaster preparedness from the life cycle of mitigation, preparedness, response, and recovery. As we think about international and the internationalization of the Emergency Nurses Association, 2020 was the year of the nurse and midwife by the World Health Organization, and also the 50th anniversary of the Emergency Nurses Association. The 2020 September issue was again dedicated to hazardous disasters with a focus on surge capacity and an increased emphasis on international education. The Emergency Nurses Association has continued to embrace being an international organization. And from 2023, there have been international scholarships to enable nurses to come from other countries to attend the national conference. International delegates are represented now in the General Assembly, giving voice to those international emergency nursing challenges. ENA created Lantern Awards to recognize the excellence in emergency nursing practice, to continue to embrace what emergency nurses do. The very first International Lantern Award winners were recognized in 2020, when the Cleveland Clinic Abu Dhabi, which opened in 2015, was recognized for shaping emergency care and receiving awards for best stroke care benchmarks in the United Arab Emirates. Also, Princess Alexandra Hospital in Brisbane, Australia, were recognized with a Lantern Award the same year. This is the highest award that an emergency department can receive from the Emergency Nurses Association. And as ENA has continued to focus on being a global voice for emergency nurses, most recent news is that as of January 24, the Journal of Emergency Nursing, the official publication of the Emergency Nurses Association, changed their subtitle to be, quote, peer-reviewed global resource for emergency nursing. In conclusion, since the early 20th century, nurses have been involved in providing emergency care to patients in a variety of settings, from first aid room and dispensaries to emergency rooms and departments to internally displaced persons camps and Ebola treatment centers. The role of the emergency nurse in the provision of care has drastically changed with changes in technology, healthcare funding, and public expectations for care. The confluence of nursing initiatives, government policies related to medical insurance coverage, pandemics, and disasters merged in the latter half of the 20th century and early 21st century to greatly impact emergency nursing practice. Two extraordinary nursing leaders working on each side of the country, Anita Dorr and Judith Calher, united emergency nurses, founding the Emergency Nurses Association. It was this unity that allowed the organization to grow rapidly across the nation and to expand internationally, supporting and crafting the evolving role of emergency nursing over the last 50 years into a true international organization. Their legacy lives on today in an organization of over 50,000 emergency nurses from 35 nations, working in emergency departments, urgent care, schools, air medical programs, and other settings where emergencies can occur. I'd like to thank the staff at the History Center at UIC, as well as the staff at the Emergency Nurses Association headquarters. And I will stop sharing so that I can take any questions that you may have at this time.
Well, thank you so much, Dr. Snyder. That was very informative. The breadth and scope of this research is just amazing. So, yeah. Any questions or comments? Jan Lee, go ahead, unmute.
Dr. Snyder, thank you for your presentation. Excuse me. I'm interested if in your more recent work as how ENA has evolved, did you find evidence of collaborations with other nursing specialty organizations? We have so many specialty nursing organizations that exist, and I'm wondering about what kind of collaboration, working together collaboratively rather than competitively, might be occurring.
There is a lot of work on that front, and there is representation through the board of the Emergency Nursing Association to multiple other organizations and committees. From an international perspective, there's great collaboration with the Nurses Association and the Emergency Nurses Organization in Canada, as well as the UK. And frequently there is cross collaboration with our president attending the UK conference and the UK president attending the conference here in the United States. But there's also been, just within the last 2 years, a greater focus, and I apologize at the moment, cannot get the name of the collective organization that is pulling together groups from different specialties so that they are working more together. There has always been a relationship with the emergency physicians group, sometimes more tenuous than others, but they are also invited to attend the General Assembly, the representative from ASAP, and to participate and hear what is happening and the concerns of emergency nurses during the evaluation of bylaws, as well as looking at position statements and things that are important to emergency nursing. And I think that a lot of this was spearheaded recently just out of the coronavirus pandemic. So if we look for silver linings of things that have happened in our country, I believe that that increase in communication and collaboration between the leadership of multiple specialty organizations is an outcome of that.
Thank you.
So I have a question, and I think it somewhat relates to Jan's question. You mentioned in the beginning of your talk a number of organizations. I believe you mentioned the orthopedic surgeons who supported the Emergency Nurses Association. And so could you, I'm thinking about sort of the medical hierarchy, right? And was somewhat struck by by the support. And I wondered if you could talk briefly, at least mention the additional organizations and how this came about within the context of thinking about sort of this medical hierarchy that exists.
So part of this was because of Judith Keller and Anita Storr relationship with the physicians that they worked with in their emergency departments. And having that close relationship with them and them being leaders in these organizations helped to pull that together. Also, Stryker was an early donator to the Emergency Nurses Association, to be able to allow them to put on conferences. The orthopedic surgeons group co-hosted the very first conference that was held. So they basically were having their conference and invited the Emergency Nurses Association to kind of tag along with that conference and have topics that were specific just to emergency nurses along with it. It was when they branched off in 1979, I believe is the date, and became separate, where, you know, they then lost any support financially from those organizations, that there was a big, you know, push for the more independence. And some of that seems to, in some conversations, have come from differences of opinion about practice of emergency nurses and the role of the emergency nurse.
Thank you. Pat?
First of all, welcome to your new role, Karen. We're delighted for you and the center, and thank you very much, Dr. Snyder. Mike, I have two questions. My experience with emergency room nurses, it's an incredibly stressful job, and it's often a time-limited position. Now, I don't know if that's correct across the board, but if it is, how did that affect the kind of organizing of ED nurses? And my second question is, when did the name emergency room, which is what I still call it, get changed to emergency department, which I struggle with, and why?
So there are nurses who are in this organization who have been emergency nurses for 50 years. It's amazing that you know, I think for all nurses, you know, the average, they say when you get out of school, is 2 years for someone being in a position before they go to a different position. And we've seen research on that. But I believe that the Emergency Nurses Association, with their push for membership, and it's an interesting organization in that there are state councils, but within each state council, there can be chapters. From personal experience, I know that as a young nurse in the emergency department, the members of the Emergency Nurses Association are the ones who, through their work, inspired me to keep going and to stay in that profession. So for others, you know, it may be that the high stress level, they're going to be out of the position sooner than others, or they may go into a different environment, but their experiences will be of value wherever they go. The Emergency Nurses Association has a young, and I couldn't talk about everything in the time limit today, but there is a young professionals group. And so as someone comes into emergency nursing, they have an option to join for free. You know, they've joined the ENA, but they can join this young professionals group to really talk about those issues as a young nurse in the emergency department. And that group has leadership. The other thing that ENA has done is that membership in the organization for those who are a student for many years has been free. So while they're a student, if they want to go into emergency nursing, they can become a part of the organization and do so for free. But I think the fact that they provide structure, just-in-time education, that there's this constant acceptance of feedback and looking at what that young emergency nurse needs. There's also an online emergency nursing onboarding program that standardizes emergency nursing education throughout the country, that an emergency department can have their new emergency nurse that's young go through. The ER title has been around for many, many years because of the thought that it was just a room. But when the Emergency Nurses Association, when it was organized, Judith Keller said, I want it to be a department because a department within a hospital has greater standing. So if they would just continue to call this a room, they didn't feel that it would elevate the need for the emergency nurse and having dedicated emergency nurses in a department. So from the very beginning, the title for nursing kept that. The difference was, from an emergency physician perspective, it was not until we saw residencies and departments developing to have residency programs, that many hospitals changed officially their titles from emergency rooms to emergency departments. So there was a early adoption, I think, in nursing and a later adoption in medicine to have that title. But I would say that emergency nurses use those two terms interchangeably.
So I won't be called on the table if I start using emergency room again.
No, I don't think so.
Thank you.
There was a comment in the chat box that said it literally was a room in the late 60s where you met your primary care doctor. The patient belonged to the doctor. And in some areas that was the case. I have a colleague who worked as an LPN in the hospital in West Virginia, where it really was the ring the doorbell. She would be caring for patients in another part of the hospital and would run down and meet the patient. And one of the challenges came that physicians stopped wanting to see their patients in the emergency department as private physicians. And that's how the evolution of emergency medicine also evolved more.
Interesting. Thank you.
We have another minute. Any other questions or comments for Dr. Snyder?
I would like to thank everyone who's present today for your interest in the topic, and I can type my email in the chat box if anyone has additional questions or would like to reach out to me.
So what are your plans for this research? What are your plans?
So of course I would like to try and publish part of it. It's a much larger volume of work. And I have applied to present part of this research at the AHN conference. So we'll see if that abstract is accepted.
Okay. Yes, we could talk whenever you have a chance. I want to sort of talk with you about you know, the internationalization of the ENA, and you know, thinking about sort of context, or you know, this idea of change over time. That's when you have time.
Great.
All right. So thank you everyone again for attending Dr. Snyder's talk. Very informative. Have a great rest of the day, and I'll see some of you at the advisory meeting at 1 p.m. Thank you so much.